Show me back. Yeah, you have my permission.
Okay, welcome, everyone this morning. So we are in the process of, everybody be excited. We're going to take our first bill. Yeah, this is called taking the bill off the wall. The very first bill that we're going to take up is H13, which is an act relating to Medicaid payment rates for home and community-based service providers and designated and specialized service agencies, who are also home and community-based service providers. For people who are new, the process that we use is at the very first time that we start talking officially about a bill. Copies coming around if anybody wants a hard copy. We have Ledge Counsel, the drafter of the bill, come walk us through the language. So the official language, and that's an opportunity for you to ask any questions that you might have about, like, what does this mean, in terms of what's it mean legally? Just so people know, I haven't, out of this committee at least, have never seen a bill leave the committee with the exact same words that it started with. So it would be very uncommon actually for that to happen. We will have opportunity to revise and edit the language. So the process will start with Jen giving us an overview, and then we will start to take witnesses, excuse me. And then we will have what's called committee discussion and markup. And that's where we have stopped taking witnesses, okay? And then it's just our committee discussion. We are reflecting on what we've heard from testimony, and we are making changes to the words at that point in time. So we don't make changes to the words kind of as we go along. We listen to the testimony, we make notes about things that might need clarification. We think about things that come up during testimony that maybe aren't covered in the bill. And then when we do markup, that's when we kind of like work together as a committee to come up with the right words to put down on the page. And then we review that multiple times actually before we vote on it. So you have ample opportunity. Okay. So that's just to give you some idea of what the process is if you've never gone through it before. Yeah.
Can I inject an editorial comment for the benefit of our new folks?
Yes.
This is a really good explanation of why, when you're asking for a bill to be drafted, getting really focused on wordsmithing and sending it back and forth to Ledge Counsel really is wasting your time, and even more so Ledge Counsel's time, because all that wordsmithing is going to happen regardless of all the great work you do. It's going to be redone in committee. So I've learned over time. Let it go the way it is. It'll all get worked on. If the idea has momentum, it will get worked on in committee.
Which could include a strike off.
Concept.
Yeah, get the concept down. Don't worry about
Exactly.
the precise wording.
So with that, we have visitors in the room. So we're going to go around the room and just do a brief introduction so that everybody can know who's sitting around the table and who is in the audience. So I'll start. Teresa Wood from Waterbury. I also represent Bolton, Buell, Score, and Huntington.
Ann Donahue, I'm from Northfield and also Berlin.
Good morning, I'm Dan Noyes. I represent Belvedere, Wolcott, Hyde Park, and Johnson.
Witness Steady, East Milton, Westford. I have to think.
And Bishop, Colchester, Chittenden 20 District.
Good morning, Todd Nielsen. I represent Brandon, Farmstead.
Hello, Zon Eastis, Guilford and Vernon.
I'm Esme Cole. I represent Hartford.
Jubilee McGill. I represent Bridgeport, Middlebury, New Haven, and Weybridge.
Good morning, Betty Alfano. I represent Essex Junction.
Lori Morse, Committee Assistant.
Dylan Langwell, Joint Fiscal Office.
Brian Plant second, live in Bristol, just sitting in. I'm on a gajillion boards and whatnot. I had the opportunity to present testimony previously to folks.
Exactly.
On homelessness and whatnot. Now I'm involved with mental health as well. Trying to help and relay my knowledge and experiences.
Thank you so much, Brian. It's nice to see you again. Okay, Jen, the floor is all yours.
Great. Well, good morning. I'm Jennifer Caddy from the Office of Legislative Counsel.
And we are going to be looking at H13, so I will put that up on the screen. So this is H13. It was introduced by the chair and Representative Noyes from this committee. And as with most bills, or all bills as introduced, it lists some subjects and the statement of purpose of the bill as introduced, but we're going to jump into the language itself. So this is an act relating to Medicaid payment rates for home and community-based service providers and designated and specialized service agencies. It starts off by amending Section 1. Section 1 is amending 33 VSA Section 900. These are the definitions in a chapter in Title 33 having to do with rate setting, largely around nursing homes, but other rate setting by a unit in the Agency of Human Services. This adds a definition. So the language on change on lines 9 and 10 is really just updating the language to be more consistent with our current drafting construct. So just saying as used in this chapter. And then a new definition for home and community-based services. And that means long-term services and supports provided to older adults and adults with physical disabilities in a home or community setting other than a nursing home, including enhanced residential care services, pursuant to the Choices for Care component of Vermont's Global Commitment to Health Section 1115 demonstration or a successor program. Home and community-based services also includes non-choices for care, home health and hospice services, adult day rehabilitation services, assisted community care services, and services for individuals with traumatic brain injury. So when we say home and community-based services in this chapter now, that long definition is what we mean.
Yeah, let's hold questions.
Okay.
Yeah. The definition stuff. Yeah. I know that too. All right.
Section 2 would add a new section to this same chapter on payment rates for providers of home and community-based services. And just before I go into this language, you'll see when we get into Section 3 that there is similar language in existing law for designated and specialized service agencies that work to some extent modeling here and using as kind of an example to put into this language for the providers of home and community-based services. And then we'll be making some amendments in Section 3 as well. So Section 2 is new language, but some of the concept is being borrowed from existing language in statute. So this is adding, as I said, a new Section 911. And it starts by saying that the Secretary of Human Services shall, which means must, determine payment rates for providers of home and community-based services that are reasonable and adequate to achieve the required outcomes for the population they serve. And when determining these payment rates, the Secretary shall adjust the rate amounts to take into account factors that include the reasonable cost of any governmental mandate that has been enacted, adopted, or imposed by any state or federal authority. So take into account the reasonable cost of anything that is required. And also take into account a cost adjustment factor to reflect changes in reasonable costs of goods to and services of providers of home and community-based services, including those attributed to inflation and labor market dynamics. So take into account the reasonable cost of anything that is required by law to be provided, and a cost adjustment factor that recognizes that costs may increase over time. When determining reasonable and adequate rates of payment for providers of home and community-based services, the Secretary may consider, so that's not a requirement, but may consider geographic differences in wages, benefits, housing, and real estate costs in each region of the state. So recognize it may cost different amounts in different parts of the state. Directs the Secretary to adopt rules. So this is going through the official Vermont administrative rulemaking process, Administrative Procedures Act. Secretary shall adopt rules setting forth the methodology for determining payment rates for providers of home and community-based services in accordance with this section. The rules shall include a process for determining an annual inflationary rate adjustment, shall set forth a predictable timeline for redetermination of base rates, and shall use Vermont labor market rates and Vermont costs of operation. And then it directs in subsection D, the secretary to redetermine the payment rates for providers of home and community-based services in accordance with this section at least annually, and report those rates and the amounts necessary to fund them to various committees, including this committee and the money committees, appropriations committees, annually as part of the agency's budget presentation. So just to stop and recap a little bit, this is requiring Secretary of Human Services to come up with a way for determining what providers of home and community-based services should be paid based on various factors, and then adopt rules setting forth the methodology for how those payment rates would be determined, including an annual inflationary rate adjustment, and then actually apply that methodology and redetermine those payment rates at least annually, and then report those and how much it would cost to actually fund them as part of the budget process.
It's now a good time to stop for a question. Okay, Representative Donahue was first and then Representative Easties.
Well, I was only going to ask with the original definition, whether that was drawn from somewhere else, or is that a new crafting for that, or?
I think it's a combination. I think we use some language that has been in existence, partly recognizing the services that are in Choices for Care, but then also including services that are broader than just Choices for Care.
I'll let Representative Easties go and then I'll look at my question.
Okay, well, actually, it's pretty much answered by the process by which the geographic differences can be adjusted and all of that. What method is, or what elements go into that decision, yeah.
Okay, thank you. We leave out a big chunk in the definition, individuals with developmental and intellectual disabilities.
We're getting into
I'm
the
gonna have a separate, I haven't read the
section. Yeah, so there's a separate section in existing law on the DAs and SSAs, the designated agencies and specialized services agencies.
Okay,
That is the same language, but for people specifically served by those agencies. So if there are,
I guess the only thing I'm,
if there are people who are getting missed by this, then yes, let's address.
that's what I was saying, because this looks like a definition that is for the whole bill, or is it just?
No, it's just actually for this, it's going in statute in this chapter of Title 33, and then it is being applied specifically to this provision on payment rates. And then we get into the next section is amending a different existing statute on payment rates for the designated and specialized services agencies. That's in a different part of the statute.
So we can talk about that in markup. Yeah, okay. Thank you.
Sure.
And this, I want to make sure I'm understanding this. So I know that there's been in statute, the stuff about the designated agencies, and this requirement for AHS to set payment rates, and they haven't done it. But that's what we're drawing from here. Is that right?
Yes, let's look at this language, and I think we can talk about it in context of this next section, because I think it's helpful to see what's underlined and what is not underlined.
All right, great. Thank you. Anybody else have any other questions on what we've done so far? Okay, thanks.
So section 3 we're amending existing law. So if you remember at the beginning of the last section, section 2, we added a new section on payment rates for providers of home and community-based services. In section 3, we are amending an existing statute that relates to rates of payment to designated and specialized service agencies. And so some of this, everything that is not underlined is existing law. Now, under the existing law, it says that the Secretary of Human Services shall have sole responsibility for establishing the rates that the various departments in AHS at the Agency of Human Services pay to the designated and specialized service agencies. We are changing that in the bill to shall determine. I think there has been some difference of opinion about whether having sole responsibility for establishing creates an affirmative duty to establish or just identifies who has that responsibility. So this language is more active and directs the Secretary of Human Services to determine the Department of Health's Mental Health and Disabilities, Aging and Independent Living's rates of payment for designated and specialized service agencies that, as we saw in the last section, same here, are reasonable and adequate to achieve the required outcomes for designated populations. And then in existing law, it says when establishing rates, this now would say when determining these rates of payment, the secretary shall adjust, we're changing from rates to the rate amounts, to take into account factors that include, and again, these are the ones we're repeating in the previous section, in the new language. This is existing language for the designated and specialized service agencies, which I will call the DAs and SSAs for ease this morning. So ask me if you forget what those stand for. So those under existing law, the secretary is supposed to adjust the rates to the extent that the secretary is establishing rates to take into account factors that include, and here again, we have the reasonable cost of any governmental mandate that has been enacted, adopted, or imposed by any state or federal authority, and a cost adjustment factor to reflect changes in reasonable costs of goods to, I'm just adding to, and services of designated and specialized service agencies, including those attributed to inflation and labor market dynamics. Again, just changing this terminology from establishing to determining. So when determining and repeating the reasonable and adequate rates of payment for the DAs and SSAs, the secretary may consider geographic differences in wages, benefits, housing, and real estate costs in each region of the state. So again, everything we've looked at that is not underlined as existing law, but has not been, to my understanding, the chair's understanding, has not been exercised. And then we get to new language. So newly added for the bill would be this requirement for the secretary to adopt rules setting forth the methodology for determining the payment rates for services provided by DAs and SSAs to individuals with mental conditions, individuals with substance use disorders, and individuals with developmental or intellectual disabilities in accordance with this section. And the rules must include a process for determining that same kind of annual inflationary rate adjustment, shall set forth a predictable timeline for redetermination of base rates, and shall use Vermont labor rates and Vermont costs of operation. And like we saw in the previous section, the secretary would redetermine the payment rates for the DAs and SSAs in accordance with this section at least annually, and report the rates and the amounts necessary to fund them to this committee and others annually as part of the agency's budget presentation. I'm going to pause there or keep going. Is that?
Go ahead, Representative Steady.
This is for you, though. This is brand new to me, so I just want to know the process, because I see you asking questions too. Once you present it, does it get changed when it goes to the attorneys? Is that what?
So what happens is that, like I said earlier, Jen's going through the language as originally drafted, okay? We'll take a bunch of testimony from a bunch of people about what they think about the bill as originally drafted. They will make certain recommendations to us. We will consider their recommendations, and then we will have discussions as a committee and then ask for changes to the language. So that doesn't happen until we get further into the process. So Jen won't be making any changes to this bill right now, but she will when we get to what's called committee discussion and markup. Markup is when we ask Ledge Council for changes in the bill. Okay?
My very first.
This is your first one.
Very first.
I do.
Okay.
Go ahead, Representative Easties.
I'm also new. Are there any instances of anyone living in Vermont that would somehow fall under section 1 or section 2 and section 3? So that the rates that are being set up for these two things might actually cover one person. And then who has responsibility, or what agency, or how does that work for setting appropriate rates? Is that even a reasonable question?
Oh, yeah, it's of course a reasonable question. And the answer is yes. So you could be an older Vermonter getting choices for care services, and you could also be getting mental health services from a designated agency. That's just one example.
But so the rates that are being charged, that the state is paying, are being determined by the people, even though they're being received by one person. It's not about, doesn't say anything about that person's plan or oversight.
No,
okay.
This is about, as the bill is laid out, the state establishing sufficient rates in order for providers to actually be able to deliver the services.
Provide the services.
Yeah,
All
yeah.
right.
Representative Noyes and then Representative Bishop.
it might be helpful to point out that in the past, this study has been done, and I'll provide it, I'll make sure you have a link to it so you can read what was produced from the last time we basically worked on a rate study.
So this, a similar bill to this, has passed the House in the past. It passed the Senate Health and Welfare Committee, and then it got, as we say, stuck on the wall, in Senate appropriations. However, during budget negotiations that year, elements of the bill were taken and put into the budget bill, and that resulted in a more modest pared down rate study for certain services.
I see.
That resulted in us learning a whole bunch, which was like residential care homes were being paid 79% under their costs to provide services. And we made big investments that year in order to bring some of them up. And for others, we did partial year, and we were, the all good intentions to continue them last year, which didn't happen. And I'm sure we're going to hear about it again this year with our budget negotiations. So
This is all very helpful. Thank you.
yeah,
Give you a good
there's a lot
idea.
of that, a lot of there's a lot of history about Medicaid rates. And that this is just like this is the tip of the iceberg, honestly, really. Yeah.
We'll give you a good idea of what to expect.
Yeah. Of what a rate study, what the results of a rate study might be. So you'll share that with everybody.
A little clarification too. This is all looking at the interaction between the state as the payer and the provider of the services. So this is not about, I mean, it may affect, and I think we'll talk about the effect that rates can have on the extent to which services are available to Vermonters, but this is not whether the Vermonter is receiving services under both of these definitions. They are not involved directly in this negotiation.
It isn't for Medicaid services. It is incumbent upon the state to establish rates that are sufficient in order for the service to be delivered. And that's the process that we're really talking about here. Yeah, go ahead, Representative Bishop.
So prior to the efforts in section 2 to include home and community-based services and how those rates would be established, how were rates established? How were they paid?
We're going to have that's a good question to ask one of our witnesses. So we're, after Jen is done, we'll be having witnesses who will be able to tell you the answer to that question.
That's good.
Okay.
Right. Right, so then we get to section.
Representative Noyes had one.
I'm good.
Oh, okay.
Then we get to section 4, which is calling for a rate study. This is a home and community-based service provider rate study. This directs the Department of Vermont Health Access, which we call DVA, in collaboration with the Departments of Disabilities, Aging, and Independent Living, the SAIL, the Department of Health, and the Department of Mental Health, to conduct a rate study of the Medicaid reimbursement rates paid to providers of home and community-based services, as defined in section 1 of our bill, where we just put in that definition, and providers of substance use disorder treatment services, including their adequacy and methodologies underlying the rates. So some of this is saying, look at what Representative Bishop was just asking about. As part of the rate study, DVA, the Department of Vermont Health Access, shall delineate a reasonable and predictable schedule for Medicaid rates and rate updates, identify ways to align Medicaid reimbursement methodologies and rates for providers of home and community-based services with those of other payers to the extent those other methodologies and rates exist, and determine ways to limit the number of methodological exceptions, times when the methodology is not being applied. And this would require that by next January 15, 2026, DVA, in collaboration with those other departments, report the results of the rate study conducted pursuant to this section and their findings and recommendations to this committee and the Senate Health and Welfare Committee and the Appropriations Committees and to the Secretary of Human Services. Finally, we have the effective date. The act would take effect on passage with the rules adopted by the Secretary that we required in sections 2 and 3 required to take effect on or before July 1st of 2026. So recognizing that it can take close to a year to adopt at least, I think, a minimum 6 months, more likely nine to 12 months to go through the full rulemaking process. There's a fair amount of stakeholder and public engagement involved.
Representative Donahue.
I'm trying to understand a little bit better how section 2 and section 4 interact, because in some ways it's sort of asking to do the same thing, set the rate, and then you would think you'd have to have a rate study to set the rate. And in terms of the timelines, do they, in other words, they do the study first and then based on that, they?
I think this was my recollection, and I think we had talked about this language a year or two ago, so my recollection may be a little out of date, but was that there was interest in having DEVA do sort of a baseline rate study to see where we are now and fully understand that in order to inform where the rate setting should go in the future.
Do you have a question? Oh, okay. Any other questions about content and sort of structure of this? So one of the things that I'm thinking about, Jen, is I'm thinking about this, and that's, so there's existing law around designated agency. So that actually made it through all of the various processes.
4 or 5 years ago.
Yeah, it was a while ago, yeah.
For this,
And it's been since I've been here, so then, yeah. It hasn't really happened in the way envisioned in the statute, at least. It may have happened in some different way. And so this is building on a law that's already in existence and thinking about it in that perspective. And, okay, I'm trying to sort of like what Ann was talking about, how the relationship of the various sections, thinking about the second bill that passed out of this committee, but didn't make it all the way to law, and how how they're intersecting in this bill now.
Right, yes, and I think this, as I recall, this bill is based on what was actually voted out of this committee, and I think out of that, as the chair said, out of the House, the last time it was worked on. So I think the bill as introduced was a bit different, and this was the result of the committee process.
Thanks. Any other questions on this particular walkthrough? Okay, great. So a little bit later in the process, there has been, so as I was just saying that the purposes of this, because these are Medicaid services and the state has an obligation to set rates that can enable the service to be provided. So if the state has failed to set a rate that is enabled the service to be provided, that causes problems. It causes specific problems with regard to mandated services. So services, you might remember the chart we saw from witnesses last week that talked about the required services and then the optional services. So the required services, if the state is not delivering a rate that is sufficient to have sufficient providers, then they're essentially out of compliance with the federal rules. So I'll give you a for instance about what has happened recently. Dentists, Medicaid rates for dentists. The Medicaid rates were woefully under market and market rates. And honestly, they're still not even close to market rates. But there was, it started in 1 or 2 counties and essentially spread statewide that they were insufficient dentists who would accept people who had Medicaid as their insurance. And so big effort to raise the rates. And essentially that was something we were out of compliance with. Similarly, on the optional services side, which I think you might recall Monica Ogilvy, was it Monica who was here? Ashley Berliner, right, it was Ashley, yeah. What is called in our state plan as optional services are things that, we wouldn't consider optional. So it's all services for people with developmental disabilities, for instance. The long-term care services and choices for care, other than nursing home services, are all optional services. So if you wanted to get your services in your home, you wanted personal care in your home, those are all optional services. So we, in our state have determined that, the state's policy is really to provide services in the setting of the individual's choice. And that means for most people that they are choosing, home and community-based services, but there is no process in state, statute for the vast majority of long-term care services, with the exception of nursing facilities, to get any kind of rate review. You recall last week in our budget, we had 20-something million in extraordinary financial relief. And we had 20-something million in additional bed days. That doesn't actually even deal with the rates. We will see in the 26 budget additional money going to that provider group because of rate changes. All this is to say that they're a unique provider system. They have a unique position in statute, and none of the other services that we rely on in Vermont have that process. And so this is to try to rectify that, so that our providers are able to at least have consideration of what appropriate rates would be. So, yeah,
I just wanted
Go ahead.
to add to that I think, which Representative Noyes talks a lot about, is important to remember that being able to provide these services at these levels theoretically should help minimize the need for the nursing home, to keep people in placements and services that are much less costly than a nursing home level of care. So essentially, it would be a long-term plan to establish savings and help people stay at home, which is a lot more beneficial for their mental health being and their well-being. So all around, it makes a lot more sense.
I do have, sorry.
yeah.
So
Go ahead.
we're talking about required and optional services. So does this take care of that as far when it says services that are reasonable and adequate? That's different than optional and required.
Right, yeah.
So how will some
Home and community-based services, in and of themselves, that there's a whole array of services that make up the sort of broad category of home and community-based services. Those are all optional services.
so will they fall under this?
Yes.
Okay. Because we've said so. I'm
Because
just
we're-
trying to.
Because we're defining it that way,
Yeah,
yes.
Okay.
Yeah, I was just gonna add to the comments before. I think one of the important things something like this does is it puts the ball back in our court as a legislature to be paying for what services cost. Because we know, we have a better idea what they really cost. And then if we say, well, we only have the money to do 90% of that, then we're making a knowing decision to not provide what's fully adequate, rather than just kind of stab in the dark saying, well, this seems like enough.
Yeah.
You know, because we have things, as we've heard discussed already this year, we have things where we know that the sustainable rate is higher and we're not funding it. And that pushes us to say, wait, you know, we can't leave things like this.
Yeah.
I remember what it was last week we were talking about, but the reach up.
Yeah, the rateable reduction.
The right, the fact that we build in a reduction of what it actually costs.
Right. Go ahead, Brenda.
You touched on this, and I actually know people personally this has affected, is the dental. That really needs to be fixed, because I have people I know personally that are being told that they only need a filling, they're having to pull their tooth. That's so wrong because of money. That I have a problem with. When they can save a tooth, but they're getting it pulled because I'm assuming Medicaid isn't covering it, and it's disappointing in this, like you said, the lack of dentist providers that are taking Medicaid. So it's kind of sad.
It is, and that particular thing was dealt in our healthcare committee. And, you know, they'll be evaluating whether it's made a difference, you know, whether the rates increase that we have made has made a difference in whether more dentists are participating and in that process. So next, we're going to move, because I see our witnesses have joined us. Next, we're going to move to hearing from the Medicaid director from the Agency of Human Services. And is Dr. Bowen going to be joining us at some point, or?
I believe so. She's confirmation this morning.
Okay, okay, so is she gonna be Zoom or not Zoom? Okay, all right, she was here. I think she'll be
Yeah,
here.
we've had them on the calendar for
Yeah.
9:45.
9:45, yeah, no, I know. But since a couple of our witnesses are already here, I thought we might get started, you know? The questions that, I think it was, you, Representative Bishop, that had before, these would be the people to ask those questions of. Okay? So welcome. Join us at the front of the table, if you will.
It's texting, Mr. Bone, let her know.
Okay. We'll do introductions because I don't think Alicia's been here yet.
For several years.
Yeah. So we have different people around the table last time. There might be one next door.
I go speaking right now.
Should try to get a couple more chairs.
Yeah.
It wouldn't be bad, just come in that, we gave us good there anyway.
And we always seem to have 3 people at the end of the table.
Yeah.
Yeah. We'll keep it.
Yeah,
We'll hide it.
We'll keep that.
No, I already have enough stuff. We'll put it right here on this, we'll hide it. Do you prefer to wait for Dr. Bowen to come?
It's entirely up to you. We're happy to get
I
started.
didn't know if you, and do you, sorry, do you have any documents or presentations?
No.
Okay. We're not used to that.
No,
Freestyle.
Yeah, we're raw dogging it, as the kids say.
is that what they call it?
Raw talking, that's
Raw talking.
That's
What does that mean? Sit on a plane without a movie or a book and you just. I don't know, I have middle schoolers.
I got a granddaughter.
There you go. Watch out for that one.
Recuse myself.
Okay, good morning. Sorry. You know, I'm, never mind. I'll tell you afterward, Monica. I'm just realizing I see somebody at basketball game, so I thought it was you, but it's not you. Okay, so welcome. We'll do a quick run around the table to introduce ourselves. Teresa Wood from Waterbury, also Sir Bolton, Fuel Score in Huntington, and to the left this time.
Faye Garofano, Essex and Essex Junction.
Kimberly McGill, who live in Bridgeport, and I also represent Middlebury, New Haven, and Woodbridge.
That's very cool, Hartford.
Son Eastus, Guilford and Vernon.
Todd Neal, I represent Brandon the Fire Station.
Devin Bishop, Colchester.
Oh, Brenda Steady, East Milton, Westford.
Eric McGuire, Rutland City.
Morning, I'm Dan Noyes. I represent Woolkit, Hyde Park, Johnson, and Belvedere.
And Donahue, Northfield and Berlin.
And we'll start and go around the table, around the outside too.
Brian Plant, just sitting in, on board of Council Services Addison County, Addison Housing Works, and the board commissioners for the Vermont State Housing.
Meredith Barrett, and I'm sitting in from Vermont State Action, and we're here today talking about the issues that concern us most in this meeting. Thank you.
Jen Harvey, Office of Legislative Counsel. Rebecca Silver, Neighborhood Principal, and Cincinnati, Dale, Department of Disabilities, Aging and Independent.
Learning Works Committee Assistant.
Great. So the floor is the 3 of yours. You can introduce yourselves, and we've just gotten a walkthrough of H13 from from Ledge Council. And so there were a few questions that came up that we said, well, wait till the people who can answer the questions. They'll be here shortly. So we're happy to have y'all here and thank you for being here.
Absolutely. For the record, my name is Monica Ogilvy. I'm part of the executive leadership team at the Agency of Human Services, and I'm also the state Medicaid director.
Good morning, everyone. Alicia Cooper. I'm the Director of Managed Care Operations for the Department of Vermont Health Access.
And we all met yesterday, or I know you all. But for those who don't, I'm Dr. Wang Jilbo, and I am the Commissioner for the Department of Disabilities, Aging, and Independent Living. Dale.
So we are happy to open it up with a handful of statements, thoughts, but really hope that this can be the start of a dialogue to make sure we are understanding what the intention and hope is for this legislation, and to see how we can partner because we very much share the same mission to be supporting our Medicaid providers, especially those that are serving some of our specialty and most vulnerable populations in Vermont. So that's why we didn't prepare anything ahead of time. Although we did prepare and discuss in advance, we wanted to make sure that there was adequate time for discussion and conversation, because I'm sure that we will have this conversation ongoing.
For a while, at least, I imagine, for sure.
There we go.
I do just want to say we are expecting 1 or 2 people to be on Zoom.
The last communication was with Stuart and Bill and not
Angela.
Angela. Is Angela still there?
She should be.
Joe Angela?
Okay, well, she will be let in when she pops in.
Okay, thank you.
So thank you. As I said, we had a walkthrough, and if there's any particular comments that you want to share about the sort of bill itself, and it might be helpful also for you to address the piece of the bill that incorporates the process that is already statute around designated and specialized service agencies, and what AHS has been doing in that regard. Because sort of the rest of the bill is modeled off of the existing statute, and to date, we don't see that happening. Let's just put it that way. But we're interested in what process you are undertaking. We know there's a whole payment reform process going on, and but when we sort of look at the letter of the law, we don't see that being carried out. So that would be helpful for you to comment on as well.
Let me just start by doing a little bit of framing around how this fits into the Medicaid program and the conversations we're having about the Medicaid program as a whole. Talked a bit about this when I came to visit earlier in the session. The Medicaid program is much broader than just home and community-based services. We see the Medicaid program very much living within all 6 departments of the Agency of Human Services and the Agency of Education. And so this is a program that is providing insurance and benefits to individuals that are low income or have disabilities. So generally speaking, we're serving over 200,000 Vermonters. About half of the kids in Vermont are on Medicaid. A third of Vermonters are on Medicaid. So we have a very strong obligation to ensure that our program as a whole is meeting the needs of Vermonters. And that's incredibly challenging at times, especially when you have budgetary constraints that you have to operate within. But overall, we're really proud of the work that Vermont has done to be expansive and inclusive in our Medicaid program. So I think it's just important in the context of all of these conversations, when we're talking about rates, when we're talking about certain populations, when we're talking about rate increases, that we're thinking about the fact that there is an entire Medicaid program that we are mindful of to ensure that we are making equitable decisions across the entire program, and not letting any one part of the program be more successful than others. We really want to make sure that we are being mindful and thoughtful, so that each part of the program can adequately support Vermonters that are reliant upon it. And so while we recognize and share your passion about the importance of adequate funding for providers, our analysis shows that payment rates are just one piece of a very complex issue. Some organizations across Vermont demonstrate success in staff recruitment and retention under current rates, suggesting we need to examine the underlying factors that drive these differences in outcomes. We as an agency are very committed to a holistic review of Medicaid program that goes beyond simply just increasing rates. We are looking at structural barriers. We are looking at operational efficiencies and regional variations in service delivery to ensure a sustainable improvement in the quality of our care. Currently, there are many different pieces of HCBS focus within the agency that are underway. To name a few, we are implementing a handful of assurance measures that focus both on quality and compliance. So these are assurance measures that have been implemented at the federal level that we are implementing here now on the state level. And we would be delighted to come back and share with you that baseline data when we have it later in the year. It's our first year reporting. But these compliance and quality measures really focus on things like, are individuals that are receiving HCBS services, are they getting a timely assessment, reassessment, update in their care plan? Are their care plans being followed? Also, what I think I'm most excited about in these new assurances is some patient experience and client experience outcomes. So really working with the clients to say, how is your experience of these services? Do you feel like you have safety in your communication with your provider? Are you getting what you need? Are your providers being responsive to your needs? And so this national data will be looked at to help us make quality improvement efforts around all the services that we're doing. So as we contemplate things like rate increases or efficiencies or structural changes, we also want to be taking into account, how is the quality of the services we're delivering? How is the compliance with our federal rules and regulations and our state statute looking in addition to making those considerations? Lastly, before I open it up to my colleagues, I think it is really important when we're talking about rate increases or rate changes that we are being very cognizant and aware of what's happening on the federal level. Congress is considering Medicaid reconciliation measures, and we have to be very strategic about what we're doing moving forward. While I would really like to think about how we can branch, expand, I am also thinking about how we are going to brace for impact for what we anticipate will be cuts to our Medicaid program. And so we are doing everything that we can to assure maintenance of the services and supports that we have already. Never mind prevent straight up cuts of service lines. And I wish I had more information about what's happening on the federal level and how that's going to impact Vermont, but I don't yet. So that is a lens with which we are having all of these conversations about rates. I think it's really important to be very transparent about that in every conversation. So I'll pause there and ask if my colleagues want to add anything.
Just that from the quality perspective, and you heard yesterday, some of the quality work that's being done already, this takes it to another level and would be in alignment with what we're doing. I think the concerns on the national level, I know we had a pause yesterday as we were watching what was going on, which seemed to ease a little bit as the day went on, but is still very much prickly and concerning, is very much on our radar. It's the Medicaid, for us, it's also the OAA dollars, the Older American Tax dollars. And so when we think about how to expand, even where it is an equity issue or a parity issue, or has something to do with the success of our providers, we are very concerned about where we can move and what we need to make sure that we're protecting to the extent that we're able to do so. So now we are also thinking with two eyes. It's good we have two, because one is on maintenance of core services and the other one is on what's the improvement trajectory.
Part of the reason I invited Alicia to be here was because Alicia has expertise in really some of the technical details around rate studies, rate increases, and rate methodologies. And so as we contemplate things like looking at our Medicaid program as a whole and what the history of rate reviews has looked like, rate increases, which is something we're deeply committed to, Alicia has that technical expertise. And so as far as it pertains to things like, rate studies that have been done for HCBS services in the past, Alicia is really a wonderful content expert when it comes to those types of details. So I don't know if you want to preemptively add anything that we've missed so far.
Just a little bit of context for folks who aren't familiar with how the different teams in DEVA try to support these activities across the agency. But within the Department of Vermont Health Access, we have 3 teams that have focus on provider reimbursement. We have a sort of more traditional reimbursement unit that maintains our standard fee schedules for things like hospital services, office visits, regular Medicaid benefit services that are kind of core to the program. We also have the Division of Rate Setting, which has responsibility primarily for setting rates for nursing homes and for private non-medical institutions. And the methodology that they use is very based in individualized cost report information for the facilities, sort of a detailed review and the individualized rate for each facility that results from that process. We also have a payment reform team that has been working across the agency for a number of years to look at the way that we have paid historically and to identify opportunities for us to pay differently, to prioritize paying for quality and value rather than sort of exclusively paying for fee-for-service reimbursement. And so sort of through those 3 different teams, we have a lot of different tools in our toolbox that we have been able to use with the other departments in the agency when there has been interest in kind of doing a review of how a certain provider group or program services are paid for. And to the extent it's of interest to the committee, we'd be happy to talk about some of the work that we've done in these different areas across departments in recent years.
You look like you were going to say.
Well, so I was just going to say, we'd love to open it up to the committee and hear your thoughts. In short, we really do share your desire to be providing more of rate increases across the entire Medicaid program. Of course, we would love to be able to do that. There's also reality that we're contending with. And so we're trying to make really data-driven decisions and balance quality, safety, compliance, and sustainability, given all of the different barriers that we know that we're realistically up against. So happy to open it up for questions.
Thank you. Yeah, I think that we share those same concerns that you have, obviously, as Commissioner Bowen experienced yesterday, there was a little proof rough rod going up here at the end of the table because we were seeing the news as it was happening and it was, obviously very alarming. So that's actually sort of the backdrop for why I think that some form of this legislation is important, is to provide the legislature with actual factual information. I think, for folks who have been here for a little while, the legislature is the one who usually provides some sort of rate increase, sometimes, not even all the time, for home and community-based providers. And we honestly don't do it based on facts. I mean, we do it based upon advocacy and little pieces of information here and there, and maybe what we did last year, and maybe what we didn't do last year. And I think that the underlying purpose of this is to provide actual facts upon which to make decisions and upon which to set priorities, exactly what you were just talking about. So I think that sort of the purpose of this, the underlying purpose of this is the same as what, you're feeling the responsibility to do, from your side of the table. We're feeling that same responsibility from this side of the table without sufficient information. Representative Noyes.
No, I just, I hear the concern about where things are going with Medicaid at the federal level. And just trying to wade through all of the information that's out there. Can we rely on Dale, Agency of Human Services, to just give us the facts, what you hear in terms of what's going on at the federal level or whatever, instead of, it would be good to have that communication, because we're all talking to advocates, we're talking to providers across the state, and of course they're very concerned. And, I can point to some news article, but, just keeping that line of communication open of what you're seeing would be super helpful. Thank you.
Absolutely. I would be delighted to be a primary point of contact in that space and for that content specifically. I'm fortunate that I'm plugged into the National Association of Medicaid Directors. And they, in my opinion, provide an incredible amount of expertise and resource to the Medicaid directors across the country and within the territories around helping us sort through the noise and saying, like, what do we actually think is going to gain some momentum? What's going to gain some traction? And so you've probably heard a handful of the different things that are being contemplated around caps to Medicaid budgets at a state level. And please, if I'm saying anything that doesn't make sense, please ask. It's helpful feedback for me in the moment. And also, this is really complex information, so I wouldn't expect anybody to know it. But maybe reducing our FMAP or the federal match level that we get. So right now we get, a federal match level for every state dollar we invest in Medicaid. They could reduce that match. They could do that across the program. They could do that for certain populations. So individuals that are part of our Medicaid expansion group, they've contemplated reducing the match just for that group. Those are people that, have procured health insurance through the expansion models. So there's a handful of different things that they've also talked about, work requirements. And at this point in time, the thing that we're seeing gain the most, or that we see there's the most consensus from different advocacy groups at the federal level, is really around reduced FMAP, state spending caps in Medicaid, and work requirements. Those seem to be the big ones. And so while we're focusing some energy behind an analysis of what the Vermont impact would be, we're not losing sight of some of that other stuff out there, because you just really never know what's going to bubble. But the truth is, we're not really going to know for another few months. It looks like reconciliation is taking 2 paths, and we'll probably know later in the spring or early summer, what's going to gain hold. But I would be happy to continue providing information to you as I learn it.
I just want to say, Dale is working incredibly hand in hand with AHS as a whole and Monica's Medicaid director in particular. So there isn't anything that we would have, information about that she wouldn't have information about. We are sharing it immediately, like 3 times yesterday, or like anything that we get. So we may get, ACL input, or Advancing States maybe pulling people together, or other ways in which we're going to have some view in. And then there's the whole, National Association of Medicaid Directors, and all of the ways in which CMS will be providing information. And we're just not going to be in different places about it. Already, DEBA, all of the departments and the agency as a whole is operating as one unit. I think, in not having been here before, I think in a way that hasn't before, but just want to assure you that if you're getting a stream of information, it's not going to be multiple streams, or you'll get different information from different places, which is really important in a situation like this.
Representative Bishop.
So I'm trying to build my knowledge base as we're moving forward with potential changes. And if I understood the chair correctly, currently the legislature has the most significant role in setting rates for home and community-based programs.
Not setting rates, but setting the appropriation.
Setting the appropriation amount. So I guess I would think that to create the greatest parity among all the various Medicaid programs, having something along the lines of this proposed legislation would help frame that conversation within the state, for state conversations about Medicaid, and give the opportunity for greater equity. Tell me where I may be
I think
wrong in that thinking, and how is the current, and second question, how is the current rate setting occurring, or how are rates set for home and community-based care?
I can answer the first part of your question. I think you've nailed it. I think we're all very much in alignment of wanting to ensure that there's an equitable way that we are reviewing rates and ensuring that we are giving rate increases when possible, to the providers that need it, or whatever the methodology really looks like as we're thinking about the Medicaid program as a whole. And so I think that there's great opportunity for us to be sharing with you as we really advance in this work, what we're seeing, what we're finding, and what our thought process is as we approach looking at all of our Medicaid providers as a whole, and kind of seeing, again, balancing what we're seeing at the federal level take hold. In terms of the existing methodology, is that something that you would be able to respond to?
I'm happy to provide more information. I think there's some variability program to program underneath the home and community-based services umbrella. And so if there's sort of a specific area of interest, maybe that's where we could dive in. But by way of example, we could think about the residential care providers, which are providing services, two different programs. There's the Assisted Community Care Services program and the Enhanced Residential Care program. And those services are paid essentially a per day rate. So if an individual is receiving the services, the provider will receive reimbursement from Medicaid for each day of services that they offer. And so I believe it was 2 years ago, we had done a rate study for those services. And the rate study was a process of engaging with providers to understand the costs that they have to actually provide those services. It was engaging with the Dale team to make sure we understood the requirements that providers had within those. And so we could be kind of gauging what the costs were associated with those requirements. And it was looking at different sorts of regional inputs around the Vermont labor market and some of the things that we might expect to be drivers of costs, to evaluate essentially how much it costs to provide those services that we are asking them to provide for Medicaid members. And the rate study showed that there was in fact a gap between our then level of reimbursement and the costs of providing those services. And to the committee's point, we had some appropriation as a result of that rate study, but it wasn't fully funded. And so there continues to be a gap. And so, this is an example where sort of the rate study mechanism that's described in the legislation is something that could be used to provide regular information. It could be updated from sort of regular cadence rather than doing it on a one-time basis, so that we know we had a gap. Now the gap has probably grown because the costs of providing services have continued to go up with inflation. And so I think it's one very isolated example, but sort of across the other types of services and programs within the agency, we've been trying to do more and more of those evaluations, especially in places where, the methodology for establishing the rate may be not well known by the folks who are currently in the different departments. I think a lot of times we have rates that were established many years ago, and they might have been established based on a methodology. They might have been established based on the funding that was available at that point in time. And so this process of doing those reviews gives us a better sense of, how far away our rates of reimbursement today are the cost of providing care is.
And Alicia's also, what you're alluding to is what took effect in July of 2023, which was the rate change based on the legislature allocation that increased along the ACCS line.
ACCS being
assisted care community service, right? And that impacted residential care homes and assisted living homes. There's other lines that Rep. Woods is referring to within those rate studies. And that's what you're talking about when you say the different lines within. Yeah. So just to bring it together with some of the conversation yesterday.
Yeah, and honestly, that's kind of the process that we're looking to sort of like make regular as opposed to one-off, Representative Easties.
So I had, when you first started speaking, you said that depending on which program you're looking at, there were lots of variables. So I'm interested to know if those variables are federally mandated variables between the ways you report, or if they're state. And because if it's state, we have some options for perhaps adjusting that and making it more understandable or more straightforward, I think, yeah. So.
I think, well, it might be a little bit of both, and I won't pretend to know all of the federal requirements on
Yeah,
some
you go
of
into
the
detail. I just want to know if it's mostly federal or if it's mostly that there's so much variation in the way things are reported at the state level.
Good blend of both.
Yeah.
Yeah. And I think some factors that go into that at the local level are things like diversity of provider availability. You know, if you've got one provider in the state providing that service that's critically in need, we have a vested interest in ensuring that that service stays in Vermont.
Right.
It's a really good question.
Representative Donahue.
So in process of being back and forth between the various committees, I was on the healthcare committee when we passed the designated and specialized service agencies piece of the statute that's being amended here. And obviously the intent of that was the same as what we're now trying to expand. But I know that there were members who felt, we heard testimony that it never really got implemented. What is your sense of that? You know, is there anything akin to what's being asked for now that did get established for the DAs and SSAs? Or did it just stall out and this will maybe get it on track? Or
it's a really fair question, and that's a really helpful piece of context for us to appreciate and know going into this and in reviewing this.
I just want, so just historically looking back, and I know it came out of the legislature, but there have been rate increases every year going back, I think, to 2020, at least that's what I have in terms of the DAs.
right, that they were never, I don't think they were ever based on actual rate studies and information coming in saying, here's how we've applied, you know, all of these factors, and
Except for FY '24. When we.
Because that's when you did the.
right,
But all the other times, exactly right. Like,
right, in terms of DAs.
Yeah.
In terms of the DAs and the SSAs, it's, you know, it's based on advocacy, it's based on seeing people saying, you know, this is how desperately we're underfunded, but in terms of having very concrete information.
Yeah, over those past 2 years, it was a range from like 0 to 8, and I think the 8 was 23. So just so that we're clear, so what you're saying is those didn't come out of or based on the rate review, except for the one in 2024.
24.
Yeah.
Right, that we
But they
didn't.
would base more assessment on the information that you had received from
Right.
Advocacy, essentially.
Yeah.
Right.
So you've been expecting a standardized rate methodology to help inform through data.
Exactly, so that we're doing it
You have-
right, because in terms of equity, you don't want to base it on who's most articulate in pleading their cause to the legislature. That's not the way
Yeah.
to do it.
I really appreciate that sentiment because it doesn't help us think about the program as a whole. And like I said, you know, we want home and community-based services to be adequately reimbursed. And people that are receiving home and community-based services also need primary care and they need dental services. And we want to make sure that those are being cared for. I heard your conversation as I was walking in. So I appreciate that we're trying to take care of the whole person and the program is intended to take care of the whole person. So I will look back into that because I'm not as familiar with what has informed past funding efforts outside of the advocacy work. So that's something that we can take back and look at the history.
Because it would help inform if we're going about this language and proceeding the right way to get what we all seem to be in agreement would be important to have.
Yeah, I think, you know, where we, from a sustainability standpoint, having process to ensure equitable rate reviews regularly makes a heck of a lot of sense. Something we're very committed to across the Medicaid program. And acknowledge that in the past, DIVA has sort of been thought of as the Medicaid program. We've broadened our understanding to appreciate that Medicaid lives way beyond DIVA. DIVA is central and critically important to the Medicaid program, but not all of it. And so we want to make sure that when we're talking about looking at rates for Medicaid, we're not just talking about what's paid through DIVA, we're talking about Agency of Education and all 6 departments within the Agency of Human Services. no qualms there. I think where I have pause isn't from a sustainability standpoint, making sure that we're not mandating or legislating rate increases for one certain service provider type over another. Because that puts us in a position where we have limited funding to say, okay, well, we are required to increase rates here. And so what are we going to cut over here?
We have Representative Eastley and then Garafano, but I'm gonna insert first. So that's the position we actually find ourselves in right now.
100%.
Okay?
Yeah.
The only people who have automatic rate increases are nursing facilities. It's the highest end of the long-term care service system. We're trying to make sure there's balance on the home and community-based side. I'd be open to changing the automatic thing on the nursing facility, frankly. I know that people listening are going to be bonkers when I say that, but
It's already blowing up my phone.
But we are trying to make sure that the investments that we're making them in the right places and having the information. And I just want to be clear also, because anything that we put forward is not going to provide an automatic rate increase. Okay, so you can rest assured about that. What our intent is that we have information upon which to base any appropriation that the legislature decides to make that may or may not be included in whatever the administration recommends to us. So we do not intend to make automatic any rate increases, and I'd be happy to adjust that current process right now. We have Representative Easties and then Representative Garafano.
Thank you. So I have two questions, and they're sort of related to exactly what we're saying. It strikes me that one, I don't even know, we'll look at the bill later, but it strikes me from a communication point of view, immediately people are focused. You came in speaking about rates increasing. That's the first part of this bill. But it seems like what's important to us is the last section of the bill. We might want to put that first and have that be the
We'll talk about that, yeah.
Okay, all right, okay, just as a question. So then the second thing for me is the notion of what the implications are to do this kind of work, to get a base study like this. And obviously you won't have an answer right now, but we would need to understand what that will require so that we can figure out whether or not we're asking something reasonable so that we can do the work we need to do to provide the services we need to provide. So
I really appreciate that, because what that signals to me is that you're aware of the fact that our resources are not infinite.
well,
And I do want people, yes, it's true. While the people I work with are just superhuman, I do want them to have some quality of life and to stay in their current positions because they're amazing. And so here. So yes, you're absolutely right. To sort of do a broad sweeping rate review of every Medicaid rate would be a massive undertaking. But we've actually been chipping away at it as part of our effort to really think about the Medicaid program as a whole. And so we could provide you with some more information on what the resources would be and if there were certain areas that we really wanted to focus on. Like I alluded to before, we've done some rate reviews for rates within certain departments, but neglected to do the same for Medicaid providers and that are sort of programs that are managed within other departments. And that's created an inequity, not by anybody's ill intent.
No.
But we're trying to,
right.
what do they say? Rising tides, all the ships.
Yeah, all boats, yeah.
But, go up, right? Yes.
Well, so I just really appreciate you.
Yeah, that's right. That's also going viral.
The
Yeah.
breadth of a conversation like this seems right to me.
Yeah,
And
I
I
agree.
appreciate that we're all in touch with one another.
Yeah.
Because it will cost you to do this, but what we need to understand how that looks and feels.
Yes, absolutely. And I think that's something Alicia can take back because it would be largely on her team.
Representative Garafano.
Thank you. Representative Eastley asked my question, so I'm not going to ask that question, but I do want to just make a comment that it would be refreshing and encouraging to have the administration come in and propose some of this versus us say, let's not have legislation that mandates some of this work that provides equity across services. And, I would encourage the administration to think about that lower tier of service that keeps people home and minimizes the need for nursing homes, and maybe shift the focus to, I know resources are limited. And I know when you're thinking about having these evaluations and studies, you have to kind of prioritize what needs to happen. But, the less legislation we have, the more time we save to have folks do the actual work that they need to be doing and providing these services. So I would just encourage our mindset to shift. So we're not relying on legislation to do this work, and administration can be more proactive at doing it.
I love that.
If I can just add to your point about what you were talking about, is basically upstream and like community-based services. And that is still the majority of the people in all community-based services, that's the services they're getting. So it'd be important to be looking at.
We can do that. It's very logical. So I'm with you on that one. And so we can absolutely come back and provide you with updates formally, informally, whatever works for you, just to let you know how we're progressing in our work to really codify this culture of a Medicaid program. I keep sort of saying Medicaid program. Again, it's sort of, the Medicaid director sitting at the Agency of Human Services Central Office is new. I've been in this role for about 18 months. And beforehand, prior to my being here, the DEVA commissioner was the Medicaid director, or the DEVA deputy commissioner was the Medicaid director. And so we never really had a high level, oversight of policy, program, and finance of all Medicaid. And so we're now in a position where we do have that resource, and we do have the ability to look at the program as a whole. So that's something we're working on anyway. And we would be very happy to bring you into it and get your input into the work we're doing. So I've made a note that we should come back and talk more about some of our assurance work as it relates to quality and compliance once we've got that baseline data, because I think those are going to be key pieces of data that are going to help inform this process. And then come back and share some of our plan on how we want to approach Medicaid rate reviews in a systematic, ongoing way.
I mean, we'd be happy to have you propose, different language.
Sure.
Representative Noyes, sorry, I knew it was on my right-hand side, but.
No worries. But really just touched on it quite a bit, that there's probably more to this than just the dollars. It's so much more in these services that Vermonters rely on, and whether it's access to services, the quality of that service, and how people are better off. That's not just like saying, okay, we need to put $10 more here and $20 more there. Appreciate the complexity of this work and yes, so thank you.
Rep. Donahue and then Rep. Bishop.
So what appears to me to maybe be a really simple starting point in terms of getting this overall picture, probably, you may well say, well, it can be simple, but you've talked about some areas where you've done, some areas you've been working on it, some that have been done and lots that haven't. They're like a simple list that says, here's all the Medicaid stuff we do in Vermont. Here's things that we have rate reviews on. Here's some we've only occasionally, and here's some that we know we really need to do because it hasn't been done in a long time.
There's an analysis underway because we have it sort of parsed out by department.
Okay.
But it's something that we're working on because we know to look at the program as a whole, we obviously need our baseline information. But we did pull together some of that information in advance of today, didn't put it in a format that was very friendly. It would be helpful for us to hear, for you to hear, the committee to hear, listed out some of the rate reviews we've done recently as it relates to HCBS services specifically. We could do that.
It'd be helpful to have it in writing.
Got it.
That'd be great. Yeah.
So that we can, because for some folks, it's not going to be meaningful without an opportunity to kind of like.
Yes, we are.
And I'm not looking at something with details even, but just like, here's the list, check.
Like we did
check,
ACCS
check,
in 22 and we did,
Yeah,
that kind of
exactly.
thing. Yeah.
Yes. I would also love that resource, working on it.
It's so critical when things are done.
Yeah.
It's an important piece of the.
Yeah.
And I do know that there are, there's significant payment reform efforts going on, particularly in Dale. DMH has undergone some of that already. And so there's, and we also have to keep in mind is not, to what you said, Representative Estes, is not only the resources required at the state level, but at the provider level as well, because it's a fairly intensive process to go through a rate review. And so, in particular for some of those smaller providers that, don't have a business office like a designated agency does or a home health agency does, but, an individual residential care provider, we have lots of them out there who are privately owned and they have to, answer all these questions that Diva might send out in terms of the rate study. And it requires resources to do. Now, if it's going to result in something, they're, usually happy to do it. So we have to keep all of that in mind and timing. And this is not something that would be done on an annual basis, for instance. It's not. I think that we're, probably more aligned about what the purpose and intent and even resources required, and what we're looking to do than, not then anything, period. Yeah, go ahead, Rep.
Just to your point, of like doing it regularly, it would also help identify, how to improve the process of the actual review, right? Like if providers are expecting the review, whatever frequency we set it at, it would help folks know what to expect. It would help your experts know, what do we actually need? What do we do with that information? Do we actually need to ask this question? Is it helpful? So in time, just having it done on a regular basis and having like a systematic way of doing it will help everyone have gain efficiencies and have a better understanding of how to respond and how to go about the whole rate setting or rate review process.
Yeah, go ahead, Representative Bishop.
There's been a lot of conversation about resources, understandably. I think that's always part of the conversation. What role or interest does the federal government express with respect to rates, if any, or do they simply, there's a pot of money and other than quality assurance and other things that they have an interest in? Do they express an interest for rules or provide any resources related to rate setting?
I wouldn't call them resources. I'm sure Alicia has lots of thoughts on this. But we do get approval from the Center for Medicaid and Medicare on our rates. And they do have to ensure that the rates make sense, so they are making sure that our rates aren't bumping up against certain caps that would raise red flags. They do have a broad degree of oversight just to make sure that states are roughly aligned, within what their rates look like for certain provider categories, if that makes sense.
Be a big outlier.
And so we do have to get approval on what our rates are. Just to add.
Those are fairly wide boundaries that they're setting.
Yes, we're very fortunate. We have a pretty high degree of budget neutrality in the state of Vermont that we've been able to maintain through our recent negotiation, which gives us a greater degree of flexibility. But again, we know that there are certain thresholds that we need to keep rates under, which is perfectly appropriate and hasn't created too much issue for us.
Good.
Yeah.
I just want to make sure people don't have like the wrong impression. So the federal government doesn't have like rate ranges or anything like that. I mean, but they do require the state to use certain considerations when setting rates. So I just want to make sure people didn't have a miss.
Yeah, and they have come back to us and asked questions about rates for certain services to try and understand what the rationale is there for, say, a rate being what it is. And oftentimes it's, maybe a state or a local lever, like we were talking about before, that is impacting what those rates are. So.
Since you mentioned the cost neutrality cap, I was just wondering, this is sort of broader and sort of like, I realize I'm probably not in any position to really say whether it helps or not, but you know, since we have an 1115 waiver and since we have a cap, and since the current government is looking at caps on things, do you think that that would have anything in terms of a positive potential for Vermont, that we kind of already have an established cap or not?
I don't have any idea whether they will see that as a good thing or see that as an way to reduce the cap.
Yeah.
But it's a great narrative to put out there that we're already ahead of.
Right, we're ahead of the rest of the country because we're already capped. We have a cap already. Yeah, it's interesting. This is first off, I just want to acknowledge all the stress that, you know, you're under in trying to navigate all of this, you and, you know, all of the folks that work in AHS and other, you know, AOE and other Medicaid providers and the community providers, you know, that I guess it just felt like I need to say that publicly, you know, the stress that, you know, yesterday put on everybody, from homeless youth providers to residential care providers to, you know, doctors and nurses and hospitals and
Meals on Wheels.
Meals on Wheels and, you know, just everything was an incredible amount.
We are living in an uncertain space.
Yeah, yeah.
We need to try to be as helpful as possible, I think, to help people to be able to live in that space for a little bit. You know, because there's this what's in our control, this that's
Exactly, yeah. Other questions or comments that people might have about the process and the purpose and who's impacted by rate setting? And I do want to bring it back to, I think it was Representative Bishop maybe asked this in earlier time, is that well, this is a process that is essentially between the legislature, the state, and the providers. The ultimate impact is on the people who receive services. So they're not involved in this process, but they are the people for whom the process takes place. I mean, that's the ultimate purpose, is to be able to provide the services that are in people's service plans and that in some cases are mandated services, in other cases not, but are all part of Vermont's Medicaid plan. So I think that's important for us to remember, particularly in this committee, that it all does come back to the people who are receiving services and the you know, is it adequate enough? Are our current processes adequate enough to do what it is that we think we're supposed to be doing, which is providing those services to Vermonters. So appreciate your openness and dialogue about thinking about, you know, how can we best do that together? And like I said, certainly open to any thoughts you might have about language. You know, it'll be a while before we get to any kind of markup, probably maybe week after next kind of thing. So that's sort of a timeline for you to think about. You know, we're obviously going to be hearing from providers. We're going to be hearing from people impacted by services. We're going to be hearing from lawyers, you know, so, you know, the gamut. And so it would be, you know, helpful for you to maybe follow along with that testimony as best as you're able to. And by the time we get to sort of the end of testimony, if you have any suggestions on language that, you know, that would be helpful to implementing the concept that we've been talking about here today, that would be very helpful.
Absolutely. I appreciate the invitation. And Chair, thank you for your kind words. It's a group effort, and it's a privilege to be in this role, working with this team right now.
And after we did introductions, I see we were joined by the Deputy Commissioner and the Director of the Developmental Disability Services Division. So just wanted to acknowledge that we did see you and ask you if you have any particular comments that you wanted to make with regard to the topic we've been talking about.
No, I don't think so. I think you've covered it all.
Okay.
You know, the whole team also works directly with the providers and the people who we serve and the families. So we for sure will be listening to what they're sharing with you, but we also have heard a lot ourselves. And so we are all definitely in this together.
Anybody else have any questions around the table? Comments? Okay, great. And you can see that Jen Carby is our legislative counsel on this task. So when you get to that spot where you may or may not have recommendations, feel free to copy Jen on those. That would be wonderful. Thank you very much.
Thank you.
Appreciate your time and attention and having the conversation. Been very helpful.
Thank you.
Nice to see you all again.
You tomorrow.
Just have a.
You just come have
every day.
Yeah. Thanks so much.
Sorry to get a lot of my children.
No, thanks.
Okay, committee, we have the Public Assets Institute going to be coming in and sharing some of their information that they have. Are you looking for a reason? You could, I mean, you could tell her she wants to come like 15 minutes earlier, that'd be fine, but if not, that's okay also. So
Would her testimony be related to H13 or just a broad overview of their work?
it's actually all related. They, I mean, it's not specific to H13. They had wanted to come in and sort of share what Public Assets Institute does. And so this was kind of one of our last, we wanted to tell you who we are kind of things. But they actually have a lot of information about healthcare, about education, about a lot of different things. And and they're actually willing to entertain questions that we might have about, you know, they might have data that we might be able to utilize. So we'll be able to ask those kind of questions.